All right, so pumps and tech and CGMs. So this was actually the first, well,
The whole what?
insulin. And it had a minor side effect where you would lose all the blood in your body within 48 hours of wearing it. So, you know, some minor problems with this version. It was massive and exsanguinated you. So now we have much better pumps. So an insulin pump is a device that delivers insulin according to how we've programmed it. Now I'm going to start with a basic insulin pump because now there are smart pumps that do more than this. But a basic insulin pump is programmed with the carb ratio, correction factor, and target blood sugar that we have ordered for you on your shot. Take people that take shots. We literally take the order from their shots and move it to a pump. It's just that the pump though is a little bit smarter than us in the sense that it will account for insulin on board that we talked about earlier, and it will lower the amount it recommends for a high blood sugar correction if it feels like there's too much insulin on board. That's why with an insulin pump, you don't have this wait 2 to 3 hour rule. You can always put in a blood sugar and carbs into a pump and follow what it says. Okay? It also has a background rate of insulin running several times an hour that takes the place of Lantus. So when you inject Lantus, it slowly absorbs in the body equally over 24 hours. With a pump, there's a rate, an hourly rate we set it at, to do the same thing. So if you have a 24 unit Lantus dose and we switch you to a pump, we put you on 1 unit per hour of Humalog to be automatically delivered in the background without you pushing any buttons, okay? One major advantage of insulin pumps is you can say, okay, I need more insulin naturally because of normal hormone rhythms. I need, like a lot of prepubertal kids need the most insulin from 9 p.m. to midnight, okay? And if we can't make the Lantus work better at that time, so there's nothing we can do. We just watch the blood sugar go up every night, 9 p.m. to midnight, okay? Same with teens, tend to need the most insulin 3 to 7 a.m.-ish. So we call it the dawn phenomenon. The reason for these patterns is hormones, okay? But we can't make the Lantus work better starting at 3 a.m. And if we give them more Lantus, they end up low at 2 a.m. and then higher later, okay? So one advantage of an insulin pump is you can program it to give a lot more at those times of day that your body naturally needs more in the background, okay? All right. Then the rest of it, when you're typing in buttons on the pump, it's literally the same thing as you doing the math calculation for carb ratio and correction factor. It's just that it's doing the math for you. It does a lot more precise dosing, so it can do 0.025 increments versus like half unit increments. And it accounts for insulin on board, so it's got like a little bit of smart feature in it, okay? It only delivers rapid acting insulin, so Humalog or Novolog usually. You know all this, we put that. There is also the advantage of that I talked about earlier, that you could actually split your meal dose where you put in your blood sugar and some carbs, eat what you are going to eat, and then put the rest of the carbs in after, okay? Big thing is you can be more at risk for ketone problems, because if the insulin delivery is interrupted, you only have 3 hour, your Humalog insulin only lasts 3 hours in the body. So if something happens, you start building ketones very soon, within hours, okay? In fact, if you have a pump site, so we do not recommend families change to a new insulin pump site right before bed, because that's the most likely time there'll be a failure. And if they go to bed with a new pump site doesn't work well, or doesn't work at all, they sleep for 8-10 hours, they wake up vomiting and already in DKA by the next morning because they went 10 hours without insulin, okay? If they do have to change their site before bed or while sleeping, we recommend they check their blood sugar 3 hours later, and if it's high, to check for ketones. Make sure it's working. We do want to make sure at school they have backup insulin, syringes, and a reservoir and infusion set. That doesn't mean we expect you to change the insulin pump site. It just means that if they have a little kid at school, then if the site fails or falls off or something, you know, the parent can come and put one on. or maybe the team knows how to do it. So you see this is the background basal rate, so that's either the basal rate on a pump or Lantus, and then these are the 3-hour big doses of insulin that cover meals and high blood sugars. So anytime you're interacting with the pump to do button pushing, that's called a bolus, and those are the meal times, the covering the carbs or high blood sugars. So anytime you cover carbs or high blood sugar, it's called a bolus. Anything that's happening without you pushing buttons on the pump is a basal rate. That's just the background rate that's running, okay? And that's pre-programmed by the user in a standard insulin pump, that rate. The supplies are reservoirs or cartridges that hold the insulin for 3 days. The family just draws it up in a big reservoir, and it's good for 3 days. And then there's an infusion set that goes on the skin, and there's many different types of infusion sets. So these are all different options. You can put the infusion sets anywhere you would do an injection. So top third of the legs, which I'm going to say because we have a lot of people that do like other spots on their legs. So we think of insulin going top third of the legs, arms, but not hitting the deltoid muscle, belly, which you can use your hip bone and your rib bone as key markers and go anywhere between. Just don't go like right on the belly button. And then you can do hips and back of the buttocks, okay? You're looking for fatty tissue, not muscle. It's going into subcutaneous, it's not going intermuscular. There are some types of infusion sets we don't recommend for kids or order for kids, and that's because they tend to kink and cause insulin flow problems. So straight in cannula sets, we don't usually recommend. You won't know this or see this anyway because it's the part that's under their skin. But they go straight in, and they're like an IV where you put it in with a needle, pull the needle out, and a little flexible cannula stays. Only they're short, 6 millimeters, straight in, subcutaneous, okay? And what can happen is they can get crunched, especially on a little person who has a tiny body. So they can crunch under the skin, you don't know it, and then all of a sudden you have high blood sugar with ketones. Because it's like it has the effect of a hose, where if you have the hose on full blast but you kink the end of the hose, nothing comes out the end. That's what's happening in these infusion sets, okay? And the only way you know is the blood sugar is high and you check for ketones and you have ketones.
So okay? Is that an alarm?
There is not a great alarm. 99% of them, that's a Mary statistic, not an actual statistic, do not alarm on you. But really, like most of them do not alarm. So if you're, especially if you're a little person, because it takes enough backflow onto the pump to trigger an alarm. So if you're a little TK kinder person who takes like, half a unit or a unit here, you're never going to miss that much insulin where it triggers the alarm. And the other thing I've noticed is sometimes the alarm gets triggered when there's not a problem, or when if you're at like T-Slim pump, whenever I wear that one, if I'm sitting in my car and I bolus, I'm squishing my infusion set and it feels the pressure and alarms me that there's backflow problem. But then they would be happening to me like every day. So, and I'm not having ketones, I don't have high blood sugars. If I stand up and redo the bolus, I'm good. But that can unfortunately lull us into a false sense of security where we get that alarm and we're like, oh, it's just the alarm because I was bent over. And you don't know that it's a real failure. So basically, we don't really, you would want to check for ketones if you get a no delivery alarm, but most of the time you don't get one.
Question.
Yes.
So let's say, like my student, the student got a, let's say, breakfast bolus at 5.5 units, right? And
yes.
Then when I check for, let's say, 10:30, the blood sugar was high still. And by the time the lunch coming in, so we did correction, and then when lunchtime, we were supposed to do bolus, and there was the trend was just keep going high.
Yeah.
And my question would be, where was the bolus, where the actual insulin actually in? Is it in the body, or where is it? Because I don't want a bolus for the lunch and then there's like a backup of insulin already.
Got it.
And
You
then
don't want
it's
the
gonna be
overlap that I was talking about, where you correct the
Right.
high and then you do it again like an hour
Right,
later, right?
Right,
So
so where is it?
So the insulin, when you bolus, and I may not, tell me if I don't answer your question, but when you bolus through a pump, it is exactly almost the same as doing a shot. It's getting delivered all at one time. Some of them are a little slower or faster than others, but within like 5 or 10 minutes, the whole dose has been delivered, okay? So the insulin on board is still representing the insulin I took an hour ago or 2 hours ago. The whole dose got into me, but once insulin's put into your body, it takes a full 3 hours for Humalog to get out of your body. So that insulin on board that's being tracked in the pump is tracking, hey, you got a big dose of insulin like an hour ago, so a lot of it's still circulating in your body and gonna have an effect. The pump, you don't have to think about whether to correct or not, ever. You just put the blood sugar in the pump and follow what it says to do. Because it's doing a way better job than we do, tracking how much circulating insulin there is. And it accounts for it and will not recommend a dose if it feels like there's too much circulating insulin. And all the pump calculators are pretty conservative, meaning that they're gonna be like, oh no, just don't correct this. So if you get a recommended dose by putting in a blood sugar, you could put in a blood sugar every 20 minutes into a pump and technically follow what it
Right,
says.
the pump make recommendation to do correction, so
Yeah.
that's why we do the correction.
Yeah.
But again, is every single pump does it come with IOB function?
Yes, I'm pretty sure every single pump comes with an IOB, insulin on board calculator, yes. I
Okay,
can't think of one that doesn't.
so that's pretty reliable, right? You're
Yes.
saying, even though that the BG trend is keep going high, and would you go for the lunch bolus even though the trend is going up? Would you still do the bolus at once, or would you rather do the like slow delivery?
I don't know what slow delivery option there is for a correction for a high.
Oh no, this is not
Right.
the correction. It's just the bolus for lunch.
Oh, okay, lunch, like a dual wave or a square wave type thing, like an advanced feature where it will give the insulin for a meal over a long period of
Yeah.
time instead of at
Like
once.
you can choose like within
Right.
15 minutes, 30
Yes.
minutes, whatever.
I would not ever use a slow feature for correcting a high. If you're talking about a meal, and that's because if the blood sugar is high, it's high, and I want to get it down as soon as I can. I don't want it to take 30 minutes to deliver because if the pump's recommending that I can handle more insulin because of whatever my number is, I want the full dose right now, right? Because I want to bring it down as soon as I can.
Wait,
But if they're eating a high-fat meal, like let's say, the main reason I would use a dual or square wave, which is an advanced feature on insulin pumps that allows you to dose the insulin over longer periods of time instead of giving all of it at one time. Most schools don't even know about that feature because a lot of our families have a really hard time using that feature, let alone whether a school should know. So you're not gonna know what foods a kid needs a square wave or dual wave, you're just gonna have to go with what the family tells you. And most people don't need a square or dual wave at school probably because they're active and moving around more. It's usually a dinner time, high fat meal situation where what I was telling you guys earlier, where like if you eat pizza at dinner, the insulin's out of your body at 3 hours when you start rising because the food's digesting for 8, you can actually account for that in the pump and tell it, hey, I know I'm gonna be high for 8 hours, can you deliver this dose of insulin over 8 hours instead of giving it all to me right now, or over 4 hours instead of doing it all right now? And you can actually tell the pump to do that. I would never probably do that personally for a high blood sugar correction though. Does that make
Right,
sense?
yeah, it makes sense.
That makes sense?
Yeah.
And especially if they're trending up, like if they're still going up and up and up, that to me is like, well, one, I'd be wondering, is the pump working? Not in the first hour. So, mind you, I get a lot of calls where they check their blood sugar and it's 400. They give a correction, and then the school's checking them every 15 minutes, which I, mind you, said not to do. But they're checking them every 15 minutes and they're like, Mary, first it was 400, then it was 415, now it's 455, and now it's 472. And it's been an hour and I gave them insulin, why aren't they going down? And I'm like, well, because the insulin doesn't do what we want it to the first hour. That is why, really. It does not do that much in the first hour. And if their blood sugar was already trending upward, and the insulin really doesn't do that much the first hour, plus these meters can be up to 20% off. So now we've got that factor. That's why I don't like people checking within 2 hours, because inevitably you're gonna freak out. You're gonna be like, why is it going up and set it down? But let's say you corrected him at 10 a.m. and he was 400, and then at 12 noon for lunch, he's still 400. That is 2 hours later. We should have had a big change by 2 hours. I'd be thinking, if they're on a pump, I'd be like, is that thing working?
Right.
And maybe I would check ketones, you know.
So to summarize, tell me if I'm wrong.
Yeah.
So if let's say 7 o'clock in the morning, breakfast bolus 5.5.
Yeah.
It should be within normal range around 10, 11,
The
right?
blood sugar.
Right,
If your settings are right,
right.
yes. And on a side note, post-breakfast is the highest spike we all get. So
Right.
morning snack, you all tend to see the highest numbers. But yes, keep going.
Okay, but if at that 10, 11, the blood sugar is still high,
Yeah.
Right.
And you haven't dosed since breakfast, right?
yes, there was
Okay.
a dose that was
At
given
7.
at home,
Yeah.
right? And the trend's still high.
Yeah.
So I guess we'll do ketones check, correct?
Well,
Because
not
that's
what,
after-
the first check you do is the first high number you see. So then you're
Okay.
like, okay, I'm gonna correct this. You're not thinking anything ketones yet. You're like, oh, this is post-breakfast.
All right, so that's
So
10.
then you correct.
Right.
It's more 2+ hours after correcting a number that was already over 300 to start.
Right.
If you're still over 300 and it's been 2 or 3 hours, then I'm red flagging. And your orders say if they're over 300 more than 3 hours, check ketones. So.
All right, so, okay, we do correction. I'm just trying to figure it out, like, how do we know if it's the pump malfunction? Because it happened like
Yes.
that's
You
fine.
do not.
And how,
That's the answer
I just
you
don't
don't
want to
know.
like, all of a sudden the king,
We
all that
don't know
straighten out
either.
and just like bolus the whole like 10 units.
I
and
just
then it's
went
crash.
to the mountains and I had altitude, I had a high fat dinner, I'm pregnant with increasing insulin needs, and my blood sugar was high and I was like, is it my site? I have no idea. The only way you're gonna know, well, one, there's some red flaggy things with sites, okay? One, if you changed it recently and you're having really unexpected highs, you might be it's more likely to fail right after you put a new one in, or if you leave it in for longer than 3 days, okay? Two, you can check ketones. I mean, if you're already high from a site failure, you're probably gonna start having ketones already
Yeah.
because of insufficient circulating insulin. They may not be to large yet, but you would have some ketones probably. So really, ketones are telling you if you have a pump site failure or not. So if you're worried, check ketones.
Okay.
And then if you're at school with 90% of them that don't give you ketone strips, so you don't have any, you're just gonna try to correct them. And then if you keep correcting and you go more than 3 hours with blood sugars over 300, especially if it's going up instead of down over hours and hours and hours, you might be red flagging and calling the family. You know, he was 300, 2 hours later he was 400, 2 hours later he was 500. I'm not sure this thing's working. Just know that the insulin, you want to wait at least 2 hours before you decide that the blood sugar hasn't been moving and isn't dropping and therefore there's a problem.
Right.
You don't want to make that assessment at 1 hour. At least 2 hours later. All right, but I wish I had a better way to tell you.
Okay, it's good.
It'd be nice if there was really good alarms, but, okay. This is a really common question I get. Why aren't they on a pump, Mary? Put them on a pump. Okay, so there are actually medical reasons we would not put someone on a pump. There are family reasons we wouldn't. And there are reasons a family might opt to not have a pump. So we actually would highly, highly appreciate schools not telling families, get a pump and it'll solve everything. Okay, so that is because you may not know some of the reasons we know for why they aren't able to get one. And plus it gives them the feeling like, as soon as you throw a pump on, my diabetes is perfect, which doesn't happen, as we all know. We know that the pumps, you can have a site failure and then be at risk for DKA, right? So are you gonna put a pump on someone who's not checking their blood sugar regularly? No, because if I don't know what their blood sugar is for 12 hours every day, they're never going to know when to check for ketones because they're not over, they don't know when they're over 300 more than 3 hours, right? And then we're worried about DKA risk. So that's one reason. Unreliable follow-up. Pumps have gotten, as you're going to find out in about 10 minutes, pumps have gotten incredibly complicated. They take a ton of education, and if a family isn't really, and they're very expensive. So to invest in someone, $6,000 to $8,000 device when they're not able to come, they're not coming to appointments and not adequately committing to what they need to be successful on it by coming to education courses, then that might be a reason a medical team might not do a pump. Families might not choose to do it because they don't want to wear a device, the education commitment, the higher risk of decay, or the cost. Okay? All of our patients are introduced to pumps if medically appropriate. May be best to let medical teams address pumps. Okay. You can ask me. Better to ask us than to ask them, though. So if you really have burning desire to. Okay. CGMs is a little bit easier. It's just monitoring glucose. So there's not really a reason we wouldn't put someone on this unless the family just doesn't want to wear it. So CGMs are a device worn on the body that measures glucose. There's 3 main components. Let me get mine. All right, so you've got, I have it in a good place to show. Okay, so there's 3 parts. One is the sensor that is under the skin. That gets changed out every 10 days with the Dexcom system and every 7 days with MiniMed. So there's only 2 main, there's actually 3 companies. There's also Freestyle Libre, but we don't use that much. So we don't cover that one as much. It's not quite as accurate as the other 2. That's the one you see the commercials for where they scan. It's really satisfying to scan it. Okay. it's like a little quarter. It's really tiny, and you scan it, and it gives you a nice little vibration beepy thing, and then it shows you the number. It's very satisfying, but slightly less accurate than the other ones, and you have to scan it. So most of our patients have type 1 diabetes. A lot of patients with type 2 are wearing that because they may not need it to be quite as accurate. It's cheaper than the other 2, and they're a lower risk often for high and low blood sugars, and so they don't necessarily need an alarm. Our kids, it's nice, I don't really want to have to scan to find out if I'm low. I kind of want the system to alarm me. Mary, you're low, right? So we don't have much experience or many people using that system. So the Dexcom and MiniMed are the 2 that are continuously monitoring glucose and will alarm you if it's too high or too low. And they involve a sensor under the skin, a transmitter, which is the gray part you can see, which is reused, and then they beam through radio frequency or Bluetooth to either an app on your phone, okay, or to a receiving device of some kind that comes with it. Or if you're using MiniMed, it will actually beam directly to the screen of your insulin pump, okay? So there's a sensor, a transmitter, and a receiving device. The receiving device is either a separate device, your insulin pump screen. That also happens with T-Slim pumps that are mixed with Dexcom, or it's going to a phone. Typically, for Dexcom, if you have an internet-capable phone within Bluetooth range of a child that's wearing this, then their families and you or anyone else, up to 5 people anywhere in the world, if they have a compatible phone with internet, can be constantly viewing their blood sugars. So right now, my husband could open his app on his phone and see that my blood sugar is 144 right now, and he would get an alert if I dropped under 40. Okay? So, this has really brought up a lot of questions on how we handle this in school settings. So we're going to talk about that. I quite honestly do not have all the answers on that, on how we're all still navigating that, but we can kind of have a discussion. But so it measures glucose in interstitial fluid, which means fluid under the skin, okay? It is not a blood glucose level. Because of that, it can be a little bit less accurate than a finger stick reading, and it can be lagged behind the finger stick. So if you just ate a bunch of food and your blood sugar is rising rapidly, you might check a finger stick and it says 200 and your CGM is saying 150 with 2 arrows up, okay? Or if you are exercising and you have a 140 with 2 down arrows, if I'm under 100 with 2 down arrows, I'm already thinking I might be low. And if I'm 120 or 140 with 2 down arrows and I'm exercising and I know I'm tanking, I'd probably check a finger stick because I might be on my way, okay? So because of that lag time, if you're rapidly rising or falling, the CGM may be behind by 10 or 15 minutes, okay? Now, the other reason for discrepancies that you might see between a CGM value and a finger stick value, this is really funny because I actually checked on break, I was 135 and it said here I was 144, but now it kind of had a 10-minute lag. Well, a little more than that. So the other reason there can be a discrepancy or an inaccuracy, perceived inaccuracy, it may not even be that the CGM is being inaccurate. There are, if you lined up 100 glucose meters here and checked your blood sugar on all of them, there'd be up to a 20% difference on what the glucose values show. Wow. So I feel like one of the problems that we're having with school acceptance of CGM values is actually that you guys are seeing a finger stick and a CGM value and they're not the same and you're like, what the heck, we're dosing a totally different dose on these 2 different discrepancies. That CGM is terrible. But really, we at clinic actually see that happen all the time with hospital meter versus home meter, or the patient brings in 2 meters and shows us. So we see it, we're much more accustomed to there being discrepancies between meters. So we're not as freaked out by the meter says 120, CGM says 140, we're kind of okay with that. They're close enough. And because we can't do anything about it. Well, the accuracy is what it is, right? But the CGMs have a MARD of 10%. There are meters out there that have like up to 20% discrepancy. So statistically speaking, the CGMs are accurate enough to dose off of, and the FDA has approved them for that use. Now, they're accurate enough to dose and treat off of, meaning that I could look at this number and say I'm 135 right now, and it's before lunch right now, I'm going to use this number instead of poking my finger. And I'm going to figure out my dose based on this number, okay? Some schools are really uncomfortable with that because they've seen the discrepancies. But, like I said, some of that discrepancy is going to happen with all different meters. I've had times where this is actually way more accurate than my finger stick, especially if I didn't wash my hands like I was supposed to. So, I'm like hiking, had a peanut butter and jelly sandwich, check my blood sugar, it's 300, and I'm like, what? 300, I'm hiking, and my CGM says 100. I wash my hands, clean them off, check it again, and this is what saved me, right? So there's times where it goes both ways, but I tell families, even if it's inaccurate, it's still really helpful to know when it's inaccurate. So, okay, let's take the exercise. Let's say my finger stick reading is 68, and this is 120. Those are really different numbers, right? Yeah. You're gonna be like, what the heck? Mary, I don't agree with anything you said in that talk, okay? But your CGM most likely is saying 120 with 2 down arrows. So if you account for the trend and you know it's lagging, you can kind of use your brain to be like, hey, 122 down arrows is still really helpful to me. I might check a finger stick now and just see if I'm 68, right? So it still can be tremendously helpful if you have the right mindset going into looking at the data and you account for the trend and you know it kind of might be a little behind. Okay, so now the controversial discussion. Because you can watch and follow people, who, when, where, how, what, all of those questions come up, right? And now you have parents who are at home who, again, keep in mind when we have this discussion, they have literally been told your child could have these horrible things happen if you, and it's true, if you leave them high all the time. Oh, but if they get too low, they can pass out and have a seizure at school. Okay, so this is like the mindset you're going into, and they're used to controlling it how they want. I have to tell you, when we had a problem with my daughter that ended up being fine, but in that 8 hours where we did not know, I gotta tell you, I don't know that you'd want me as a parent either. I mean, really, because that is your kid. You have a way you want to do it. You know your kid, and all of a sudden you're like, here, my whole life of my child is now in your school's hands. Like, that is really scary. And so then if they're following at home and they see something, they're going to be like, okay, they're high, do something, you know. Oh, they're low, is someone there? But what is realistic? What are our expectations? I do not have the answers to this. Neither does our whole community. I have talked to a lot of school staff and a lot of different medical teams on this, and generally, I'll give you sort of the consensus. The consensus is and this does not mean I'm right, this just means generally what most of us in the diabetes community feel can happen, is that if we're capable of seeing a low at school, then we probably should have someone that can respond to that. So, meaning we don't want little Susie in TK with a blood sugar of 40, and we have the technology to detect it, she can't feel her lows, and we're just like, nope, the schools can't follow, so Susie's gonna stay 40. You know, we're not really okay with that. Now, are we okay with the school, though, having to sit there and be like this, and then go to the bathroom like, Susie's 132 now, and then you're going pee while you're watching the phone? No, that's crazy. We've had schools say that families want them to take the thing into the bathroom. So, okay, so no, we don't want that in either. So where does that leave us? So that leaves us with, we would like, and our orders say, for the school to have the capability of responding to a low blood sugar alert. Now, that means that an adult in the classroom needs to be able to hear if the thing alerts, okay? This gets really messy when you talk about recess, because I do not want a yard duty like this, following Susie around while she plays, but I would also really like for there to be an alert that someone can hear at some point, I mean, when she comes back in from recess. So then that brings up the recess issue, brings up the following situation. It's kind of like, well, if it's lunch recess and she's 40 and she's out in the playground, who's going to hear it alert? And is it reasonable to have someone be standing next to them in range that they could hear it? I don't think so, that's reasonable to have. I also think that's really intrusive to the kid's day, right? Like, yard duty within 20 feet of you at all times. If my son had to do that, he'd freak out. So that does make following having someone at school, because the parents aren't actually responsible for the management at school. So it can't be a parent that's following and responding to all these alerts, right? They're not even there. They might be at work, and really it is the school's responsibility. But now we've got this following situation, like, how do we do that? And so what we have kind of said is, the recess thing is still gray area. I don't know what to tell you on that one. But someone at the school should be able to respond to a blood sugar alert. The alerts need to be in reasonable thresholds. The family can choose the alert. So it might be at 70 or 80 for a low. And if you're getting a bunch of alerts for highs after meals, we often tell families to turn off the high alert at school or make it at least 300. So if you're having an intrusive alarm constantly for highs, and you feel like the school's having to respond constantly, like I said, I don't like anything interrupting that we can't do anything about. So it is not helping if every day after lunch we have a high alert because of the postprandial post-lunch spike, right? So that's not the kind of alerts I'm really looking for response from the school. I'm really looking for someone to be getting alerted for a low, okay? Either an adult, and that often they're with the teacher, so either the teacher has to be able to call and say, Susie's CGM alerted, come down, or you guys are following. So if you follow, I feel like, it's my own personal opinion, in terms of the equipment, the family's responsible for providing you with the equipment you need to manage your diabetes, right? So I don't feel like the school has to buy anything. If they have something, okay, but I do think it's nice for the school to let them use their Wi-Fi if they need it or something like that. But Yes, so then you kind of have to figure out who's following this person and how are they going to respond. So a lot of schools, the families will give them a device, and it's a follow device, like an iPad or whatever, and it's in the office, and whoever's covering the office is the one that would respond to the alert. Sometimes it's a nurse, but then you'd have to be able to get a hold of someone on site to treat the low. So I don't know if any of that answered questions, but that's sort of where we're headed and what multiple different clinics have said. Also, many clinics have said we won't sign super complicated orders for schools regarding CGM values with a bunch of numbers and arrows and if this, do that. But for us, we feel like if the school is okay with that, and the family presents you with a plan that meets within our 20% insulin adjustment allowed, then you guys can agree to doing that, but we're trying not to send you like 3-page complicated CGM interpretation guidelines orders, okay? So let's see, did that cover most of our CGM controversy? Let me see, there were some good questions on it, so let me see if I got,
Mary,
yes.
sometimes we have trouble with Wi-Fi in our health offices.
Yes.
So that's another issue too.
That is an issue. I feel like if you don't have reliable, like if it's really a big issue, like you would almost need the teacher to respond to a receiver alert in the classroom. Because that doesn't require Wi-Fi or following or anything. That doesn't mean the teacher has to be responsible for treating them. It would mean the teacher has to call the person who
somebody
is.
know, yeah.
But again, that goes to where they have to have reasonable alerts set.
Yeah.
Like I don't want someone setting their high alert to 200 and the teacher calling 10 times a day.
Right.
Again, I'm thinking like when we write these orders, we're thinking like one low a month at the most. And not really having to respond to high alerts unless, if you have high alerts and it's been more than 2 hours and you can correct, fine. But I don't want like 6 times a day high alert responses, Again, it goes back to that 5 minutes. In my head, no more than like 5, 10 at the most, on average, that a kid is missing class or peer time. And you don't want the teacher to feel like they're constantly calling, So you kind of have to talk with us if you're having those issues so that we can work with the family on the alarm thresholds. Or you can talk to them first and just say, hey, this is really interrupting your school day. Is there anything we can do? Do you want me to talk to their team? Do you want to talk to them? Can we change the threshold? Because we're, that kind of thing. Let me see what, okay. We talked about that. We talked about helping with pump practice with our maybe future simulators that we can kind of practice pump buttons. We talked about that way early on. Oh, this was another good question. Hold on. Okay. Yeah. Okay. We covered all that. Donated equipment, that was another question, it looked like people were worried about setting CGM precedents, and even if they got donated equipment to follow someone's blood sugars, that they'd be worried about using it. I feel like we're sort of entering this realm of that being the standard, is that the school just needs to be able to respond to an alert, and you can figure out how to do that either by the receiver in the classroom or following. If you do the receiver in the classroom, you have the recess PE situation that I can't answer. I don't have a good answer for. Really, it goes to like, if you can, it'd be better to follow, because then you have an alert even when they're most at risk, when they're running around. And in terms of equipment, I think usually, I think it's okay if the family gives you something, so that I don't know that that's setting a bad precedent. Okay. So then the other question was digestion and insulin timing. So people were seeing that right after they dose for lunch, there'd be 2 arrows down. So they were asked, the question was, how do we know that the insulin timing was right for that person? So yes, digestion is individual. So some people might, and also depends on the type of food you eat. So if you eat pizza, it's going to take a really long time to digest. If you eat Skittles, it's going to be in you right away, right? and then most foods are somewhere in the middle. You also can have people that seem to digest faster than others, okay? And if you're active right after you dose, you're also you might not digest all that food right away, and you're just gonna tank, and then as soon as you stop exercising, you'll start digesting the food and it'll go. That's why it works to our advantage if people are active right after lunch. If you are chronically seeing lows right after lunch, then yes, I would talk to the medical team about maybe their lunch timing isn't correct for that kid. Like, let's say they start out 80 and then they're running around like crazy right after lunch and they end up 60 before they ever start rising from their lunch. Maybe that's a kid we're gonna dose after if their starting blood sugar is under 150 or something like that. So we don't know that's happening, so you let us know if that's a pattern you're seeing in terms of insulin timing. The other question was, yeah, I think it says accommodating the tech-savvy parents' drive to treat the numbers occasionally hinders the ability to care for the whole patient in a learning environment. I think we kind of addressed that. It's true, additionally, yeah. Okay. And then more here. Okay. Yeah.
So I had a question about, I've heard from a parent that at 250 or above, the brain starts to not work as well in the classroom. Thus, the parents, have wanted us to have student do deep knee bends or something when he reaches that. And it's kind of a snafu.
This is a really hard one for me to answer because
What's
there
your
is
thinking on
actually there's some.
Uh-huh.
Okay, so I've been waiting for this actually to come to our orders. I find it very difficult to assess how well a child can learn based on their blood sugar number. Meaning, like, there's been families who write their number on the top of a test because they feel like they don't do as well if they're high. There actually is evidence supporting that in sports and academics, that if your blood sugar is really high, or if it's low, obviously, that you may not perform it optimally. What to do about that is a whole nother story, because I feel like ideally you'd have in range numbers when you take a test, but the reality is these kids are in range maybe 50% of the time. So what do you do there? I don't have an answer for that. I would say if it's our patient, call me and we have to talk about it, and if it's not, talk to their medical team and see what patterns they've seen with this kid in particular. I mean, if it's not happening very much, I guess that would be okay. Kind of hard on the kid to have to, like, you're about to take a science test, so do some squats.
They'll think, what?
I feel like I wouldn't be okay with that as a person with diabetes. So that one I might talk to the medical team that cares for that patient, and just make sure they're aware of it and maybe come up with a plan. I think it's hard because there is some evidence that it does affect, and actually on not the same note, but on a kind of related note, there was some big studies they did thinking that severe low blood sugars when you have a seizure and whatnot can impact long-term cognitive function, okay? So they did MRIs on people with type 1, they did all these studies. What they actually found was that chronic high blood sugars actually cause some level of cognitive impairment, like permanently change your brain in a bad way. So, and then they did, like, maybe if you've had 3 or more seizures, you might have some changes in your brain from lows, but really there's just, all the evidence just keeps piling up from how much damage high blood sugar exposure does, and there's not that much in terms of what low blood sugars do. So, not that we want a kid passing out and having a seizure, but I'm just saying, in terms of long-term impact, like, that is why medical teams are so, let's not let them be high, because that is where we're seeing every study that comes out is just, like, even worse. Like, you just keep going, really? It does that too? So that's a hard one. I don't know how to answer that one. Okay, more questions on CGM?
And the high blood sugar, I know it can affect their vision if it's long-term, but at the time you're checking their vision, if they have a really high blood sugar, will it affect it?
That is a great question. You can have blurry vision temporarily from high blood sugars. especially after diagnosis. It can take a few weeks to go away. So that's a hard one. Although what's interesting is I've had one kid, most of my kids who show up with visual acuity problems, and we are thinking, oh, maybe it was just you were high blood sugar, they've all ended up needing glasses. So I really haven't actually seen it where you thought they needed glasses and they didn't. I had one kid that we thought he needed glasses, then he didn't, and like 6 months later he really did.
So it's better to refer them.
Yeah, it's better to just
do
send
another
it.
check and
Yeah,
refer them.
just send them.
Okay.
That was a good question though. Okay, so sensors can be placed anywhere that we talked about that shots and pump sites can go. They've only actually been FDA approved for adults on the belly and kids on the belly and bottom. And so, but we all wear them everywhere and we tell our families to wear
I
them.
have another question.
In fact, some people do better with it on their arm in the terms of accuracy. Yes.
About the CGM. So you're saying there's a G6, I guess it's the newest one.
Yes.
And
Yeah.
so you're saying it's okay to dose off of that all the time?
Yes, that is what
Even
I'm
if
saying.
they're, say their CGM says they're 50.
Yes.
So we should, okay. So no
So-
finger stick.
That is a good question. Let me say it again. So because also you brought up a good point. I did not clarify the types of Dexcom CGMs out there. So there are all different versions of Dexcom. The most recent one is G6. It actually isn't that much more accurate. I don't even know if it is even more accurate than G5. But G6 has been does not require calibrations. So you guys probably don't do the calibrations at school anyway, but calibrating is taking a finger stick reading, telling your CGM what that reading was so that it can correlate the numbers it's getting from under the skin with a blood sugar number that correlates to you and your body, okay? The G6 comes pre-calibrated, so there's no finger sticks required for the whole 10 days you're wearing it, and it's been FDA approved for dosing off of. So essentially the G6 could almost entirely replace finger sticks. You can treat and dose off of it, and that's in all your orders from our team. Okay? The only time you cannot use it is if you're checking a blood sugar 15 minutes after a low. It needs to be a finger stick. Now, there are reasons you would check a finger stick though. If the family's like, I don't know what's wrong with this sensor, it's not working. I mean, you're gonna check finger sticks. You're not gonna dose off one that's, sometimes you just get a sensor that's running inaccurately, and you're just gonna do finger sticks while you're waiting. Now the G6 is not supposed to have an interference with Tylenol in your body, but I would still be weary if there's Tylenol, acetaminophen in the body, so taken in the last 8 hours or so, it can affect accuracy of older CGMs. So I'm still not convinced yet that, I wanna see more data before I'm convinced it's okay. So your orders actually say, like, do a finger stick 10 to 15 minutes after treating a low, anytime the CGM is not running accurately per family, or if you've noticed it's not running accurately, if there's Tylenol in the body, those are reasons you would do a finger stick. Also, it doesn't mean you can't do a finger stick. Like, let's say the scenario I gave you where they're running around like crazy at PE, it says 120 with 2 down arrows. You know that kid, whenever the CGM says that, there's a lag time and you think he's gonna get low, you could bring him in and do a finger stick. It might actually be 68 by then, right? So it doesn't mean you can't, it just means you don't have to regularly before lunch do a finger stick. You can just use the value that's on there. Like I would just open this at lunch, say I'm 132, and dose off of this number. And our orders also on the new flow chart say, if the CGM shows under 70, a finger stick shows under 70, or the CGM says under 100 with down arrows, all of those you can count as a low and just treat without a finger stick. It is very, very, very freeing as a patient to not have to finger stick all the time. It is a quality of life issue, and the difference in this accuracy and quality of life, I just feel like it's not that different, and it's actually probably more accurate than a bunch of meters out there.
Mary, can you just clarify? So you said if it's under 100, so 99 or below with down arrow.
Yes, you can treat it as a low if you want to.
Okay.
That way the kid doesn't have to come do a finger stick if they don't want to.
What is the range between the for the sensor and the
for them
Oh.
being apart from each other.
Yes, you mean like the transmitter and the receiving device?
Yeah, the transmitter.
Yeah, so basically it's Bluetooth range for most of it, so it's usually, kind of depends on the classroom you're in or wherever you're in. So mine would probably work across this room, but you kind of have to see. So it's probably something like 10 or 20 feet, but you kind of depends on what's going on in the room. And which receiving device you're using, so, yes. Okay, let's see. We did the 3 parts, we did the 2 companies. So this was actually I actually been on a CGM since 2006. So this was my first graph I ever had when I first put it on. And I had no idea I was high all night all the time. Because see, I was fine in bed and fine in the morning. And so then after wearing the CGM, I was able to really adjust things and get it way more in range. So this is just to show you, it can really make a big difference on blood sugars. And it can also improve quality of life for people that aren't having to finger stick check. And you also, it teaches you things that, if I told a kid, dose an hour or dose 15 minutes before you eat so that an hour after you eat, you're not 400, they're going to be like, oh, okay. And then you live your life and you're like, it's so inconvenient to dose 15 minutes before eating. But if you are, and you don't have to see the high blood sugar because you're not on a CGM, but when you wear a CGM, you have to sit there and watch it go to 400. So it can do behavior modification and teach you things that in a way more powerful way than someone telling you can. Okay, we did not touch on this next subject, which is automated insulin delivery devices. So, an artificial pancreas or closed loop is a device that combines an insulin pump and a continuous monitor and says, hey, we have this insulin delivery system, we have a thing that's monitoring glucose, why aren't we putting them together and saying, having it predict when there's going to be a higher low and have it adjust the amount of insulin that's getting pumped out based on that, okay? So that's what they did. A true artificial pancreas would be, we wear these devices and no one's involved at all. And the blood sugars say 70 to 140 100% of the time. We are not near that right now. But we're at the beginning phases where we've been able to take people who are in range 50 or 60% of the time and get them in range 80% of the time with these, with less low blood sugars. Most of the time when we get people more in range, they have more lows. With these devices, you can actually have less lows, more time in range, less highs, and a lower A1C, which is awesome. But we're at the very beginning stages of it, so there's some downsides. So the only FDA approved one that does this is the MiniMed 670G. So basically what it has is it looks like this. It has a transmitter and sensor right here, and then an infusion set here, and an insulin pump here. The glucose value is beaming to the pump, and then the pump has a carb ratio set that is always the same as what you use now, but it does not have a correction factor or basal rate set by the user when it's in auto mode with a blue shield on the front, okay? What it does instead is it learns your body over the course of the last 5 days or so. It learns your blood sugar patterns, learns your body, and it kind of decides what it wants your basal rate and correction factor to be, and then it adjusts it every couple minutes, all day and night, depending on what your current glucose trend is. So if it thinks you're going to be low, it stops all your insulin, and then waits until it thinks you're going to go up more and go to range. If it thinks you're going to be high, it pumps out a bunch of extra, trying to get you down. So its target is 120. It's trying to keep you at 120 all the time. That does not mean you stay at 120 all the time, it just means you're 70 to 180 more often, okay? So this is what happened to teens who went on it. So the teens who were on regular pump therapy, the gray is what their blood sugars did, more lows, more highs, and this pink is what their blood sugars did on auto mode. It tends to do really well at night when you're not eating anything, because the system can just keep you in range when you're not stressing it with food. So it did a 0.5% reduction in A1C for some people and 1% reduction in others. I've seen some people go from a 10 point something A1C to 7 point something when we put them on this. But you still have to do all the same work. You are still checking your blood sugar, you are still telling the system what your blood sugar is, you are still giving it a correction dose it recommends, you're putting the blood sugar and the carbs in at every meal and giving the dose it recommends. This system has not been approved for dosing off the CGM value. So we still have people finger stick value checking, which maybe that's the one she's on. But we still have people finger stick checking. And so basically, in terms of what you're doing at school, it's literally exactly the same thing as if they didn't have if they didn't have this pump. So there's nothing new. I will tell you what impacts you though, is one, you may see more time in range, which is great. And two, if you see the blue shield up on this screen, there's a blue shield meaning it's in auto mode, and they get a low blood sugar, their system has already cut a bunch of insulin from them, trying to prevent that low. So if you give them the full low treatment, the 15 carbs that you normally would, they're probably gonna go to 300. So we usually recommend less carbs for someone who has a blue shield on their MiniMed 670G pump, and your orders from us say 10 carbs for people like that. Now, if they're a little TKK with that, it's gonna be even less, but. Okay, that's not a good option, or may not be a good option for people with low amounts of insulin needs, because the system can't adjust enough to make it work as well, and they also haven't tested it as well. They're in the middle of testing it for younger kids. Kids under 7, you have to be at least 7 or older to go on it right now. Honeymoon, it depends on your blood sugar, but it might actually run you higher on this system than you would if you were in honeymoon, so we might not put you on it yet. If the family's not ready to spend a bunch of time learning this system, because it's more involved and complex, then we may not be a good option. This system right now has a lot of extra alerts that you're responding to, and a lot of check your blood sugar right now. I want to make sure we're doing okay because it's the first system that's come out, and they were really, really, really cautious on safety. There's like a million triple checks, but that means a lot of work for the user sometimes, where it's like, oh my gosh, I see something. Can you check your blood sugar and make sure everything's okay? So we have families who are just so frustrated because they're like, it's constantly asking me to check my blood sugar. But they just updated their transmitter, which has reduced some of those nuisance alarms, so that's good. There's no share feature yet. That's about a year away from happening. So some families don't choose this pump because they want to be able to remotely view the data. And then there's also the Tandem T-Slim pump is now partially linked, or is linked to the Dexcom CGM. So the same one I have will beam from the transmitter straight to a T-Slim insulin pump, okay? That one is not fully automated yet, but what it will do is if it senses you're gonna get low, it will stop insulin delivery, trying to prevent the low. So again, you're doing all the same stuff at school you always did, but if someone's on a smart pump like that, you may need a little less carbs for low treatment.